Stage 2 colon cancer, the management is still something that we debate, many years after we have established a standard for stage 3 colon cancer with the use of 5-FU oxaliplatin. And the reason we debate it so much in stage 2 colon cancer is that it's uncertain which patients are most likely to benefit from adjuvant chemotherapy. And the data to drive that decision, unfortunately, is not definitive in terms of declaring a meaningful survival benefit with the use of adjuvant chemotherapy in stage 2 disease. So our current approach, and this approach has been in place for many years, is to try to risk stratify patients with stage 2 disease. So we currently already do that with our staging classification. So we look at T stage and try to refine patients based on whether they're 2A, so T3N0, versus 2B, which is T4A-N0, or 2C, which is T4B-N0. And 2B, and particularly 2C stage colon cancer, has been associated with prognoses that are probably comparable to like 3A and 3B, or sort of early node positive disease. So we recognize that T stage is an important prognostic factor in terms of determining who may benefit from adjuvant chemotherapy. And probably the second most important factor is the mismatch repair status. So we don't see deficient mismatch repair commonly in stage 2 colon cancer, probably 15 to 20% of the time. But when we do see it, those patients have a very favorable prognosis and are unlikely, in fact, do not need adjuvant chemotherapy. And so that helps really refine our classification, but we know there are a number of other clinical pathologic features that have been recognized as high-risk features that may warrant consideration for chemotherapy. Those remain things like inadequate nodal sampling, perineural invasion, lymphovascular invasion, positive margins, but those are still limited in their ability to truly identify those patients most likely to benefit. What excites me most in the landscape of stage 2 colon cancer now is the opportunity for liquid biopsy or using circulating tumor DNA to truly evaluate for the presence of minimal residual disease. The early data is quite compelling that this is really going to help us prognosticate in a much more informed fashion who is most likely to recur in node-negative early stage colon cancer. The question then will be, can we change that outcome? Like, will adjuvant chemotherapy convert these patients with ctDNA positive disease to ctDNA negative disease, and will that improve outcomes? And so we in Canada will be participating in the NCI-CTEP NRG 005 study called COBRA, which is basically going to be looking at the utility of allocation of adjuvant treatment in stage 2A, so sort of low-risk stage 2 disease based on ctDNA positivity. So that's I think quite exciting and will inform the landscape and help move the needle forward for us.